Welcome to Migraine and Other Headaches at Work. Thank you for joining us today. This webinar is part of our Harnessing Talent Alliance series. Harnessing Talent Alliance for Recruiting and Retaining Canadians with Disabilities is a 3-year project funded by Employment and Social Development Canada. We would like to thank our 9 founding partner organizations as well as our academic team. If you would like to learn more, please visit our website at harnessingtalentalliance.ca. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program, through the BC Government, as well as donations and memberships to WWI. We thank our program partners, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions related to the presentation. We will collect questions submitted throughout the presentation and follow it with a Q&A based on the questions submitted. Any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website along with the slides. You will be emailed the direct links for all of these items when they're available. Today, we're welcoming Dr. Anna Andreou. Dr. Anna is the Director of Headache Research at the Headache Centre at Guy's and St Thomas NHS Trust and King's College London. She's also a senior lecturer within the Wolfson Centre for Age-Related Diseases at King's College London. Anna completed her PhD in neurology at the Institute of Neurology at University College London before continuing her research at the University of California in San Francisco and Imperial College London. She has received several awards, including but not limited to the Senior Research Fellowship of the Migraine Trust, the Research Innovation Award from the Medical Research Council, the Early Research Career Grant from the International Association for the Study of Pain, and the Headache Research Excellence Award from the International Headache Society, IHS. Having held the role of Chair of the Trainees and Residents Special Interest Group of the IHS for 4 years, she is currently Chair of the IHS Electronics Media Committee. Her research interests include understanding migraine and cluster headache pathophysiology and developing novel therapies for the prevention of headaches. Anna, welcome. Thank you for making the time to teach us about migraines and other headaches at work. I will let you take over without further wait.
Good afternoon or good morning, depending where you are. Thank you for the kind invitation. Actually, one of my passions these days is to sit with managers at different workplaces and discuss about migraine and other types of headaches and how employers can help their employees suffering with these disorders. I think this is the best approach rather than trying to come up with guidelines or sitting in committees that are trying to make a change. If we don't have the direct access with the managers and the HR people at the workplace, I think it's really difficult to implement any changes or understanding of how disabling this type of headaches can be. So thank you very much for the invitation. So I will start with a definition of what is a headache. Many of you may actually experience a headache, any type of headache. Essentially, when we use the word headache, we mean any pain in the region of the head or the neck. However, in headaches, the pain is actually felt mostly in intracranial structures, not in the brain. So the brain itself doesn't experience pain. It can process the pain, but it doesn't experience pain. However, the membranes surrounding the brain have what we call sensory fibers, and they can sense painful changes to their environment, as well as extracranial structures like the skin and the muscles are also innervated by these sensory fibers, and hence they can sense and send painful signals to the brain. So a headache can affect nearly everyone. So even if you don't have a headache, when you were young and you had a hangover, you may have woken up with a headache. So it's quite frequent. And actually, when it comes to headaches as a disorder altogether, is the most frequent cause of consultation in general practice and in neurological clinics. And it does represent a huge socioeconomic burden. I will give you mostly data coming from UK because this is where I practice, but across the world, it's a very costly symptom and disorder. So for example, in the UK, all headache disorders are estimated to cost about 250 millions per year. But actually, the actual cost may be up to 7 billion if one includes the cost of the healthcare, so visiting the doctors and getting the medications, but also the loss of productivity because patients will either miss work, or even if they are at work, they're disabled and cannot actually perform to their full capacity. So headaches can be very disabling. So there are a number of different headache disorders and conditions. And the International Headache Society for some years now has been publishing what we call the International Classification of Headache Disorders. And it separates the different headaches in three main categories. We first have the primary headaches, and this is where my focus will be today. And in primary headaches, we mean that the headache is the actual disorder. And this is what we have to treat. This is what we have to deal with. Secondary headaches are any type of headache which is attributed to a different problem, to a trauma, to a different intracranial disorder, to an infection, and so on. And usually this type of headache will go away if this secondary problem is treated. So in this case, the headache is a symptom. It doesn't have to be treated. You just focus on what is causing the headache. And then we have the painful cranial neuropathies and facial pain that are rare but can be very disabling as well. So as I mentioned, the main focus for today will be on primary headaches, which are the headache disorders. So I'm going to start with tension type headache. So if someone comes to you and says, I have a headache, it's like a pressure around my head. So this is the tension type headache. This is the most common form of a headache. It can affect up to 80% of the population, and it's a bit more prominent in women than in men. The pain is characterized usually by pressure on both sides of the head or around the head. Most patients will describe it as having a band around their forehead, and the pain usually is mild to moderate. So most of the patients will be able to handle the pain. The pain doesn't worsen by movement, is not associated with any other symptoms like nausea, for example, or sensitivity to light, which are common symptoms of migraine, and some people may confuse them. And it can last either a short period of time or it can last for several days. Some patients may also describe some tenderness on the muscles around their head. So for example, in this area here, some patients will say, oh, you know what, actually I can feel this trigger point, which can be part of the pathophysiology of the tension type headache, although we still don't understand much about what is causing tension type headache. What is important to remember, especially for employers, although we describe this as a common non-disabling type of headache, some patients may actually develop what we call a chronic tension type headache. This definition has been given by the International Headache Society, and usually patients with chronic tension type headache are diagnosed because they have more than 15 headache days per month for at least a period of 6 months. So this can be quite common. It affects about 3% of the population. And when it becomes chronic, it can become disabling. So one needs to be careful about patients with chronic tension type headache. The other thing we haven't mentioned is that this type of headaches, all the types of headache we're going to mention today, can actually coexist with other types of headache. So it doesn't mean that someone who has a tension type headache doesn't have a migraine, for example. So they may still get migraine attacks, but on other days they may experience what is called a tension type headache. Although there is a bit of a debate in the field on whether in migraine patients, tension type headache is also another form of a headache, or is it part of the migraine? Even if it's not described as a disabling headache attack, when it becomes chronic, this type of headache can be also disabling. And although I said it's not disabling, headache, as we said, is a pain, so there may be still discomfort. So you may have employers still complaining about the discomfort they feel from tension type headache. And that can actually affect a bit their concentration levels. Any type of pain can affect the concentration levels, which means that these employees may have problems performing at their best at work. Obviously, as we said, the chronic form is more disabling, and it can result in work absence. So bear that in mind. And the best advice will be to actually ask your employees to consult a doctor so they can get a proper diagnosis and proper treatment. So chronic tension type headache can be well managed before it becomes chronic, when it's just a headache day here and there. Patients can use simple analgesics, over-the-counter analgesics, but I have an asterisk there, and I want to draw your attention to that. Maybe you heard, or maybe you haven't heard, this term called medication overuse headache. This is actually a secondary type of headache that is quite common in patients that we see in neurological clinics or tertiary headache centers, because most of the patients who cannot manage their headache well, what happens is that they start overusing the acute analgesics, and for reasons that we still do not understand, but they may share the same brain networks involved in addiction. So the brain gets used to these acute medications and is giving more headaches to the patient because it's asking for the medications. And the headache will mimic the tension type headache symptoms, or even the migraine symptoms, but it's a secondary type of headache. That's why it's important to actually ask your employees to consult a doctor, because if they do suffer from a primary headache disorder and the medication overuse headache, the treatment for the medication overuse headache can be very simple, and it involves actually stopping the analgesics. But at the same time, we try to offer preventive treatments to help patients actually go through this period as better as possible. Withdrawal from the acute medications may actually cause more headaches, but this is a temporary problem, and if an employee has a preventive medication in place, actually the headache can be resolved quickly, and then the doctors will be able to actually see the phenotype of the primary headache condition. They will be able to diagnose the actual tension type headache and treat the tension type headache, rather than dealing with a secondary headache caused by the medication overuse of analgesics. Now, I will move on to a different type of headaches that are grouped together, and they're called trigeminal autonomic cephalalgias. So this, you may have heard them or you may not have heard them. It's a group of conditions that include what we call cluster headache, which can be episodic or chronic, paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attacks, hemicrania continua, and so on. So this group of headache disorders are more rare. However, they've been described as being amongst the most painful headache conditions and most painful conditions or episodes ever felt in humans. I won't cover all of them. However, they all share similar symptomatology and even similar pathophysiology. But I will focus mostly on cluster headache because it's the most common of the group and is believed to be the most painful condition ever felt in humans. So before focusing on cluster headache, just to give you a bit of an overview of all of these disorders, what is different between them is that the duration of the attack may last either a few minutes, like up to 4 minutes in SANCT, or up to half an hour in paroxysmal hemicrania, or up to 3 hours in cluster headache. But then the frequency of the attack changes. So usually with the short-lasting attacks, the frequency of the attacks is much higher. So SANCT, SUNA, and hemicrania continua can be experienced up to 200 times a day. Then paroxysmal hemicrania, more than 5, but obviously less than the 200 attacks, so 5 to 20 is the average. And cluster headache, which can last up to 3 hours if untreated, can occur every other day or up to 8 times in a day. The asterisks there indicate that some of these conditions can be actually treated effectively with a medication called indomethacin. Indomethacin is a non-steroid anti-inflammatory drug, not widely used because it can cause side effects. It's not very good for the stomach, but patients suffering from paroxysmal hemicrania and hemicrania continua, when they take the indomethacin, the attack can switch off completely. So actually, we can use indomethacin in the clinic as a diagnostic tool as well if we're not certain about the diagnosis of the trigeminal autonomic cephalalgia. Now, let's move on to cluster headache. So again, I'm not certain whether you have ever heard of cluster headache, but surely you have heard of multiple sclerosis. You know what multiple sclerosis is, MS. But if you haven't heard of cluster headache, actually, you should know that it's as prevalent as MS. It can affect up to 1% of the population. But it's a shame that not many people are aware of this disorder. And we, as headache experts and within the International Headache Society, I think we need to do more to raise awareness about this terrible headache disorder. I call it a terrible headache disorder because it used to be called suicidal headache because the headache is so extreme. Patients in the past, in particular, they didn't have any treatment, so a lot of them committed suicide because they couldn't bear the pain. This type of headache disorder affects mostly men compared to women, or more men compared to women. In the past, the ratio was about 1 to 4 women to men. However, nowadays we see that there are more women being diagnosed with cluster headache. I don't think this happens because something in the environment or changes in our lifestyle make cluster headache more prominent in women. I think it's because the expert, the neurologists and the headache experts have become better in diagnosing cluster headache in women. Because migraine is quite common and disabling in women, maybe in the past some cluster headache female patients were given the wrong diagnosis of migraine, and hence the difference in the ratio we see like a decade ago compared to what we see now. However, the diagnosis can be difficult, and if one is not well trained, maybe patients will actually get a delayed diagnosis. In our center in London, we actually see that most of the patients have a delay of at least 4 years before they're diagnosed with cluster headache. And imagine that this is a very disabling, painful condition. So this patient for 4 years received no help, and obviously we need to do better in diagnosing the cluster headache maybe earlier in the care of the patient before they actually reach an expert neurology clinic or an expert headache center. What is very characteristic about cluster headache, but also of the other trigeminal autonomic cephalalgias, is that it usually comes in bouts. What does that mean? It means that the attacks suddenly begin while the patient was absolutely pain-free before, and they will last for a period of time. I said short, but it can be up to 2 to 3 months. And then they will stop, and there will be a remission period again. So the patient will experience absolutely no attack, and whatever was actually triggering the attack during the bout will not be triggering an attack during the remission period. And then again, this cycle will happen again in 6 months or in a year's time. There is a bit of seasonal occurrence of these periods of cluster bouts. Some patients will experience their bout early in the spring or later in the autumn, usually around the clock time change. So this periodicity actually is quite interesting when one studies this type of headaches, and we look at the biological clock of the brain, the hypothalamus, when we are trying to understand a bit better what is causing this type of headaches. Another interesting aspect of this cluster headache disorder or attacks is that they can occur mostly at night. But what is interesting is that they occur at the same time of the day. So again, there is this biological clock ticking as to when the patient will have the attack. And again, we're still looking within the brain area called the hypothalamus to understand what is actually triggering this headache disorder. So it's a brain disorder. And unfortunately, about 30%, so 1/3 of these patients may move on to develop a chronic cluster headache. What does that mean? It means that there is no remission period. So the patients will continue having attacks day in, day out, or every other day without actually having a break. So this is a very disabling form of cluster headache, and it can be a disaster in someone's life if they move on to develop a chronic cluster headache. So the pain characteristics can be quite different from what we discussed with the tension type headache. First of all, as we said, it is regarded as one of the worst pains a person can experience, and even female sufferers describe it as worse than childbirth. The pain, or this excruciating pain, usually occurs just behind the eye or on the temporal region. It's nearly always on the same side, but some patients may experience that in their next bout, the headache may come on the other side. But when they get the attack will be always on that side and not move on to the other side or be on both sides. It will be just on one side. And it's like a stabbing rod, like a burning rod stabbing the eye. That's how patients describe this type of pain. As we said, it can last up to 3 hours, and it's accompanied with other type of features or symptoms. For example, the eyelid gets swollen or watering, the eye is watering, the nose is running, or it may be blocked. They may experience full ear, some facial sweating, and edema, and so on. And that's why we call it autonomic cephalalgia, because these are what we call autonomic features or autonomic symptoms. Another interesting characteristic of this type of pain is that when the patients experience the attack, they are restless. So it's not like a migraine, for example, where the patient, any movement of the patient of the head will actually make the pain worse. In cluster headache, the patient just want to rock their head, they move up and down, they become quite restless, and this is very typical of a cluster headache attack. Do we have treatments for cluster headache? Well, yes and no. One thing everyone should remember about headache disorders is that unfortunately we don't have a cure. So any treatment is there to actually help the patient relieve the pain during an attack, or hopefully to prevent further attacks from coming. So the acute treatments are the treatments we can use to actually stop an attack or reduce the pain experienced during an attack. So when we want to treat a cluster headache attack, patients can use high flow oxygen using a special oxygen cylinder with a high flow mask that they have to keep on their face during the attack. And usually it can block the attack in about 50% of the patients or even more. Sumatriptan injections are quite effective in stopping the cluster headache. Sumatriptan is actually what we call a migraine-specific treatment, but it can be used in cluster headache as well to stop an attack. Also, there are nasal sprays that patients can use. Some patients don't like using needles, especially when they feel quite restless during an attack. So there are some nasal sprays of sumatriptan and zolmitriptan, another migraine-specific treatment of the same class as sumatriptan, but they're not as effective as the injectable form of sumatriptan. Also, the FDA approved a non-invasive neuromodulation technique called vagus nerve stimulation that involves a small machine that patients can put underneath their neck, press hard there so they can stimulate what we call the vagus nerve. And some studies show that it can actually stop the cluster headache attacks. I have to admit, in our hands, we didn't have great success with this treatment. However, I have to say that the patients we see in the clinic are usually very difficult to treat patients. So maybe we're not the best place to actually comment on the efficacy of this treatment. In studies, it has been shown that it can be effective in some patients, and it's still an option that patients should be considering. At the same time, and the best will be if when the bout of cluster headache begins, the patients are offered not just treatments to stop their attack, but also preventive treatments that will hopefully shorten the bout of attacks. So rather than lasting 2 to 3 months, it can last for 4 to 6 weeks. Verapamil, it's a type of a hard blood pressure medication that is quite commonly used as a preventive treatment of cluster headaches. And then there are some other drugs like methisertide, lithium, corticosteroids, and topiramate, which is an anti-epileptic treatment. Vagus nerve stimulation, again, may be used as a preventive treatment. What we commonly use in our center is an injection at the back of the head, blocking a nerve called the greater occipital nerve, and we actually use local anesthetic and steroids. This is a very effective treatment, but unfortunately, it can be only offered in specialized centers. And in our center, at least, we do offer a rapid access to our patients. So as soon as a patient enters a bout of a cluster attack, they can give us a ring and we bring them in quite quickly to offer this type of treatment. And hence we can reduce the period of the bout. Another type of treatment, of preventive treatment, is an invasive neuromodulation treatment again, called sphenopalatine ganglion block. Again, this involves injecting local anesthetic in the just behind the nose. There is a ganglion that is involved in the pathophysiology of cluster headache, the ganglion, the sphenopalatine ganglion. And by blocking that ganglion, also the frequency of cluster headache attacks can be reduced. But this is a very, very specialized treatment, again, offered to very, very few patients who may not respond to the rest of the treatment. Now, what sort of advice shall we offer to employers and colleagues of patients with cluster headache? Well, when one of your colleagues experiences an attack, there are certain things you should be doing. First of all, it will be nice, as I said, the attack can be very violent. Patients will be restless, they may want to cry out, some patients may just want to bang their head on the wall. Just allow them a private room so they can experience their attack, but make sure that they are safe. Maybe a good colleague, a good friend from the work can be present in the room, or make sure there are no items they can use to harm themselves during an attack. Also, it will be great if they can store their treatments, their acute treatments at work. So the sumatriptan injection somewhere where they can safely store and dispose the injections after they use them, and also somewhere safe where they can store the oxygen bottles. As we said, oxygen, high flow oxygen, it's an effective treatment of cluster headache. And the other thing is important to help your employees to avoid triggers. During about stuffy, warm environments can actually trigger an attack, and this can be used in research practice as well. If we have cluster headache patients and we want to research the attacks, we may just put the patients in a stuffy, warm room, and that will trigger an attack. So the best is if you can be flexible and just move that person to a non-stuffy environment, a different type of office that can help them to avoid this type of trigger. And also a very common trigger for cluster headache attacks during the bout is alcohol. Even with a glass of beer, the patients can induce a cluster attack. A cluster attack can be triggered. But as I said, this happens only during the bout. So outside the bout, the patients, which is a very interesting thing that we see in cluster headache. So patients can drink alcohol, no problem at all. During a bout, having a glass of alcohol will actually trigger an attack. So if you can advise your employees with cluster headache to avoid this type of triggers and help them to avoid this type of triggers, that will be the best. But there is more that you can do when it comes to cluster headache. You have to, first of all, understand their severity. Remember, we said this is the worst pain ever experienced in humans. It used to be a suicidal type of headache. So people need to be more aware of cluster headache, and managers need to be trained to actually support their staff. And even if a patient is well managed by their doctors and the medications they're taking, these medications may actually cause some side effects that can be disabling. So again, understanding that this may be the situation, and any sort of going back to work with some disabling side effects is affecting their performance. It's something that managers need to be aware and need to understand that it's because of this disorder. When a patient enters about, usually it's impossible for them to keep going to work at least as regularly as they were before, and hence employers need to be more flexible. Obviously now with the COVID situation, we all became very flexible and we can work from home. But if you can offer flexible solutions in working hours, days, and environment for your employees suffering with cluster headache when they enter about, that will be ideal. Also, make sure you are in contact with your employee during this period. As I said, it can be a very difficult period for them. If they don't have good support, good medications, it can affect a lot their psychology, and they may develop all sorts of psychological problems. So just make sure you are in contact with them, you ensure that they are safe, and that you can support them in any way you can. And also, if they haven't had any specialized consultation, you can advise them to seek the advice of a headache expert and look around for urgent cluster headache clinics. As I said, this is something that we offer in our headache center, and actually we see lots of patients that we will normally not see, because to book an appointment, it may take up to 6 weeks. So if these patients didn't have access to an urgent cluster headache clinic, if they were to contact for an appointment at the beginning of their bout, we will have seen them in clinic at the end of the bout. So that would have been no help at all. But the model of urgent cluster headache clinics has been adopted by many centers around the world. I'm sure in Canada there will be some as well. So I highly advise you to suggest a visit to an urgent cluster headache clinic so the patients can receive very early on a preventive treatment. Also, because this is a very disabling condition and a rare condition, not everyone understands this type of headache. And the best people who understand this are other patients who experience the same type of attacks. So another way to support your employees is to suggest them to join a charity that deals with the cluster headaches. In UK, but also in other countries, OUCH is the main charity for cluster headache. It's the Organization for the Understanding of Cluster Headaches. And they do an excellent job in actually keeping the momentum in their patients, suggesting treatments and sharing their experience, and also guiding patients to expert headache centers where they can receive this type of urgent attention when they enter a bout. So I think being in touch with a charity about this specific problem, it's very important, and all our patients have found it extremely supportive when it comes to being in touch with other people who understand their disorder. Now, I will move on to migraine, which is a very common headache disorder. A primary headache disorder. You can see that across the world, it can affect up to 15% of the population, affecting mostly females compared to males. The World Health Organization actually ranks migraine as the third most prevalent condition of the world. So 1 in 7 people is affected by migraine. And as an indication there, I included that it's more prevalent than diabetes, epilepsy, and asthma when we combine them together. In UK, it's been estimated that every day there are at least 190,000 attacks. So you can imagine what that scale will be in Canada or in any other big countries around the world. And although the headaches can come and go. At least 3 out of 4 patients will experience at least 1 attack per month, but at least half of them will be severely affected by migraine attacks in a month. Another aspect to consider when we talk about migraine is that it's not just an adult disorder, it can affect children as well. It can be quite prevalent in children, up to 10% under the age of 12. And then when it comes to teenagers, 18% of them may be suffering with migraine, and it can equally affect males and females before they enter adulthood. So the reason I'm adding this information here, because as employers or HR managers, most of you may be dealing with adults, it's just so you're aware that some of your employees may have children who suffer with migraine, and they may need to take time off so they can look after their disabling child. So just remember that, and remember that this type of disability is not constant, and they will be back at work as soon as this period of attacks is gone. Migraine is age-specific prevalent, so it peaks during the reproductive years, especially in females. Obviously, hormonal changes in women play a big role in this, but also stress. Obviously, in adulthood, life can be hard. We're all quite stressed about managing life, work, home. So stress and hormones actually play a huge role in the prevalence of migraine, especially in females. So when it comes to the disorder, as I said, it does come with episodic attacks again. So in its episodic nature, as we call it, patients will experience less than 15 headache days, migraine days per month. But it can also become chronic, which means that the patients will have more than 15 headache days per month. Usually there is a family history of migraine, and this can be also a diagnostic tool in the clinic. But we didn't manage to find any genetic links, or maybe we didn't find any specific genetic links to be accurate. So we think it's a multi-genetic condition. Anxiety and depression are quite common in patients suffering with migraine. So one needs to be aware that, especially in chronic migraine patients, they may be quite depressed in their life because of the condition, because of the disability of the condition. And another interesting aspect of migraine is that it can be triggered by a number of things, and these things can actually point out to the biology of the disorder. So a very stressful event or a relaxation from a very stressful event can trigger an attack. As we said, hormonal changes in women can quite often trigger attacks. Changes in the sleep pattern, for example, missing sleep or extra sleep during the weekend, migraineurs will wake up with a migraine attack, as well as missing meals. It's another trigger of migraine. Some patients complain that weather changes can trigger attacks, either a very bright environment or a very humid environment or weather can actually trigger an attack. Again, alcohol can be a migraine trigger at all times, actually. Light in an office, for example, bright light, smells. Some patients complain that the smell of petrol, fuels, or the smell of certain perfumes can actually trigger an attack. And as we said, medication overuse, again, this is a secondary type headache that can be present in migraine patients, and it can trigger more attacks. Now, the attack itself is not limited to the period where the patient feels the pain, and that makes migraine a very disabling disorder. So it usually starts from a phase called the premonitory phase. Now we'll explain in a minute what that is. Then it moves on to the head pain phase, which can be on one side most of the time, but it can also be on both sides. Usually it's throbbing in nature, and any movement can worsen the headache, and hence patients will prefer to lie in a bed during a migraine attack. Some patients, about 20 to 30% of the patients, may also experience some neurological disturbances just before the headache begins. This type of disturbances are usually or more commonly described as visual symptoms, and the picture I have there just describes how my visual aura looks like. But also the aura may be of a different type. It may be a language type of aura. It may affect the speech. So for example, when I get that type of aura, I do confuse the two languages I speak, and some people may make no sense when they're talking during a migraine aura. So migraine is more than just a pain disorder. It's actually a clinical syndrome characterized not just by headache, but by many other associated symptoms. So you can see the different phases of a migraine attack and all the symptoms that are present during these phases. And many of these symptoms can be disabling from very early on, before actually the headache pain phase, the head pain phase is present. Obviously, the headache phase is the most disabling phase of the migraine attack, but even after the headache attack or the headache disappears, the patient still experience a sort of a hangover phase where they can still feel tired. There may be some confusion or lack of concentration, and this can still affect their performance. And obviously, like with other type of headache, the other types of headaches we discussed, the episodic migraine, which means that an attack is coming, can last up to 3 days, and then the patient gets some sort of a break before the next attack. It may develop into a chronic migraine form, which can affect up to 2% of the population. And by chronic, we mean when the actual headache is present at least on 15 days per month for more than 3 months, as described by the International Headache Society. You can see at the bottom there I have the calendar of a random migraine patient with chronic migraine, and you can see that on most days there is headache present with a variable intensity, which can be quite severe on some days. So you can imagine how disabled these patients can be. So with all of these symptoms, one can imagine that migraine is a complex disorder of the brain, and it can be quite disabling. So actually, the World Health Organization suggests that migraine is the leading cause of disability among all neurological disorders, and the 7th among all diseases. It has been estimated that a migraine patient actually may spend 5% of their life experiencing migraine attacks, and this is a big percentage of someone's time, of someone's life. So you have to imagine that these patients are disabled about 5% of their time, and is the second most frequently identified cause of short-term absence from work. So bear in mind that migraine patients may actually need to take time off because of their attacks. It's quite costly in the society. So as we discussed earlier, the cost is not just on the treatments or the visits to the doctors, but also because of the absence from work or the lack of concentration during work. So in Europe, for example, it has been estimated to be up to 27 billion euros. in US up to $20 billion. In the national health system, it can be also quite costly. At least in UK, we estimated that that migraine alone costs about £150 million per year. And however, this is just a conservative estimate, because the real estimate is around 3.4 billion if one considers again the time patients take off work. When it comes to migraine treatments, there are several options. Again, we have the acute treatments that the patients will take when they experience an attack, and the preventive treatments that are usually offered to patients with a higher frequency of migraine attacks. Although there are several options, not all of them work for all patients, and some of them come with side effects, so this is something else we need to consider. In terms of acute treatments, we have the triptans, which are what we call the migraine-specific treatments that were designed specifically to treat migraine, and they can be effective in 40 to 60% of the patients. Paracetamol, non-steroid anti-inflammatories, aspirin may be also taken to stop the headache pain, the head pain, but bear in mind again what we discussed earlier about medication overuse headache. Additionally, there is a neuromodulation technique called transcranial magnetic stimulation that has been found to be an effective acute treatment, but it's not widely available. As far as I know, it's available in US. I'm not certain about Canada. In terms of preventive treatments, topiramate and propranolol are usually the first line treatment. These are oral medications. Acupuncture and riboflavin are suggested in UK as second line treatments. However, they're not as effective, and essentially the recommendation is due to the reduced cost for the NHS. Other preventives involve different oral treatments like amitriptyline, pisodifan, venlafaxine, candesartan, and so on, as well as injections like the greater occipital nerve block that we discussed earlier in cluster headache as well. Additionally, non-invasive neuromodulation techniques like the transcranial magnetic stimulation and the vagus nerve stimulation have been shown to be effective preventive treatments for migraine. When it comes to chronic migraine, Botox, you may know Botox from its cosmetic use, but it can be also a very effective treatment for chronic migraine patients. Up to 65% of patients may find this treatment effective. And recently, we have a newer class of preventive treatments called CGRP monoclonal antibodies. These are injectable treatments that patients usually have to self-inject once a month or every 3 months. And they are against a molecule called CGRP that has been found to be involved during migraine attacks. These treatments, as I said, are new treatments. They are offered by specialized centers. They are quite expensive, so maybe not all patients have access to them. And the other problem with them being newer treatments, it means that we don't know their long-term effects. And we only now started to understand side effects that appear with this treatment outside the side effects reported in clinical trials. So, what sort of advice can we offer for migraine at the workplace? First of all, employers need to understand that migraine is not just a headache. It is quite disabling, and patients may have to be absent from work because of the disability a migraine attack may have. You also need to understand again that even if a patient is taking effective treatments, they may cause disabling side effects. So this can further affect their ability to concentrate and to perform as well at work. Patients do need to be supported, so it's nice if managers are trained to listen and support the patients. Be able to offer flexible environment, flexible hours, and other flexible working solutions, so the patients can still maintain their job while they offer some sort of flexibility around their attacks. You should also advise your employees to seek for a specialized consultation at a specialized neurological clinic or a headache center, because as I said, there are lots of treatment options out there, and they may be able to access even the newer treatments that can be effective for their migraine. And also getting support from charities that are specific for migraine. For example, in UK, we have the Migraine Trust, can be also quite helpful for these patients. So they feel like they're talking with people who can understand their condition and how disabling their condition can be. Okay.
There you go. Perfect.
Other advice you can offer to your employees involves asking them to recognize and avoid their migraine triggers and to have a more balanced schedule in their life. So, for example, having a good posture can be quite helpful. Avoiding stress or having some sort of advice on how to cope with stressful situations can help to avoid migraine attacks. Again, avoiding bright environments, reducing caffeine intake, which has been shown to trigger attacks, avoiding smells that can trigger attacks can be quite helpful. Also, maintaining their sleep and eating patterns. Again, it's all about maintaining a balance in the biology of the system that is involved in triggering attacks is quite important. Avoiding alcohol, which is a common trigger of migraine attacks, and exercising regularly. This is quite important because migraine, when patients experience a migraine attack, any movement can worsen the headache. So often migraine patients will avoid any type of exercise, but actually research has shown that over time exercise can actually reduce the frequency of attacks, so it can be used as a sort of treatment for migraine. I think at the workplace, the important is to create a migraine-friendly environment. So looking after the desk, the exposure to noise and light and smells, also helping your employees to cope with stress can be quite important. But I think the most important aspect is to discuss with them their needs and make sure you understand the disabling nature of their condition and help them to remove the stigma of this invisible pain. Often what we hear from patients is that they're trying to hide their suffering and their pain because they feel that their employers don't understand them, and they fear they may lose their job because of not performing as well when they have an attack. So this is the stigma of migraine, and if you can help them to remove the stigma and be able to speak out about their attacks and help them to manage them better at the workplace, that would be the best we could do for them. Also, something that becomes a bit of a trend these days in UK and Europe, but it can be adapted in every company essentially, is creating a migraine escape room. So when a patient gets an attack at the workplace, remember any movement can make the pain worse, so many of them wouldn't like to leave work and travel back home. All they need is a dark, quiet room where they can take their medication, maybe have some sleep, which can be an effective migraine treatment, by the way, and just stay there for a few hours until they feel better and are able to either go back to work or be able to move and go back to their house. So the migraine escape room can be also a quite useful room to have at the workplace. So, take-home message, now coming to the end of the presentation. You have to remember that although headaches are intermittent and the headache is usually not present the whole time, it can be quite disabling. Remember, we discussed cluster headache, the worst pain ever experienced in humans. We discussed migraine, very common and disabling type of headache. So they can be quite disabling. There is no cure for headaches, but there are effective treatments as long as the patient can access them. So you have to empower your employees to seek treatment and improve their well-being and help them to reduce the stigma associated with the disability of their headaches and provide them with support, especially those who are disabled by headaches and they're stigmatized because of their headache condition. Here you can find some useful tools for headaches at the workplace. Most of them are about migraine, but the last one, Fit for Work, has a nice blog for cluster headaches. And with that, I will leave you. That's the end of my presentation, and I hope I haven't given you a headache.
Thank you so much, Anna, for this extremely interesting webinar. I'm sure our audience would agree that we have learned a lot today. If you don't mind, we'll move on to the Q&A session, and I would like to ask the first question. So what is the effectiveness of physiotherapy, postural training, ergonomics in your work?
Well, it depends on the type of headache. So again, if the headache is associated with some neck problems, which it's a different type of headache, usually we call it occipital headache, then it can be effective. In migraine conditions, as I said, the posture can actually, or a bad posture can be one of the triggers of headache. So again, helping the patient to have a good body posture can be effective in avoiding some migraine attacks. But overall, is not the first-line treatment. It can be an adjunct treatment that can help some patients, but not all.
Perfect, thank you. And in the case of headache medication overuse, you said that stopping the medication will fix the problem. So what alternatives does the patient have to treat primary and secondary headaches?
Well, so it depends on the country. So different countries practice differently when it comes to medication overuse headache. For example, when I was working at US, I remember there the consultants wouldn't treat any patient coming in with medication overuse headache. The advice was that they had to stop, so go cold turkey, and when they stop the acute medications, then come back to the clinic so they can treat the primary headache condition. Nowadays, we understand that this is not a good practice because during the withdrawal period, the patients will experience exacerbation of their headaches because they get these withdrawal headaches. So the best way around it is to introduce a preventive treatment and then slowly start reducing the acute medications. So when the preventive medication is working, then by reducing the acute medications, you go through this withdrawal phase in a more smoothly way. And studies have shown that by stopping overuse of medications can improve headaches up to 50%. So it's very important that patients are well supported to actually reduce the acute medications. But one needs to understand that the reason the patients are abusing these acute medications is because usually they don't have any other option. It's because they don't have a good preventive treatment to help them, either because they haven't been they haven't attended a proper consultation with headache expert, or because whatever preventive treatment they're using is currently not working. So we need to be to collaborate with the patient in order to help them go through this medication overuse withdrawal phase.
Makes sense. Thank you. And in your opinion, are there any effective non-medicated alternatives to treat certain headache disorders?
Yes, remember we discussed a few options with non-invasive neuromodulation techniques. So we discussed transcranial magnetic stimulation and vagus nerve stimulation. So these are non-systemic, non-invasive treatments that have very little, if none, side effects. And at least in our headache center, the experience we have with transcranial magnetic stimulation has been very good. Its efficacy is nearly as good as Botox, and patients like to use it because it improves a lot their quality of life without offering any other side effects. And they're non-painful. Patients can use these treatments at home, so they involve portable devices that the patients can take at home. So these are good alternatives that lots of patients opt to have them, again, because they don't like using oral medications that come with lots of side effects.
Perfect, thank you. And what types of accommodations should employers consider when dealing with productivity?
Do you mean, I assume here the question is what sort of workplace adjustments, right?
Yes.
So especially for migraine and even for tension type headache, adjustments to the environment are very important. I showed you in the last couple of slides that good office solutions that help the patients having good posture, also non-stuffy rooms where patients can avoid exposure to bright lights, smells, and noise can be quite effective. Also, techniques for the employees to cope with stress, which is a very common trigger for migraine, and also advice on maintaining a good schedule in their life, especially when it comes to sleep and eating patterns. It's very important that they don't change these patterns, especially during the weekend, because usually this can trigger a migraine attack.
Perfect, thank you. And I think one of the angles of this question is, so are those accommodations proven to increase productivity?
Well, absolutely, because if a patient, even outside a migraine attack, this is something we haven't mentioned, even outside a migraine attack, patients can be disabled if they're exposed to a bright, noisy space. So by adjusting this environment, you can actually help the patients to concentrate, their employees to concentrate better at their work and increase their productivity. So one thing that is very characteristic of migraine patients is what we call lack of habituation. What does that mean is that if a person without a migraine is exposed to, let's say, to a room where there is a clock ticking every second, after a while, this non-migraine person will get used to that ticking of the clock. They will buffer that noise and they will be able to concentrate at work or to any other task they have. If you put in the same room with a ticking clock, a migraine patient, that tick, tick, tick will be bothering them. They cannot habituate to it, so they cannot silence it in their brain. So that can be confusing, and that can actually reduce their productivity. So this lack of habituation, as we call it, is very characteristic of migraine patients in particular, and any adjustments to help the patients having a better environment where they can actually concentrate can actually increase their productivity.
Perfect, thank you. And then two last questions. So the next question is, why is migraine a condition that is sort of separated from other headache conditions? For example, why does it stand out?
Well, I wouldn't call it separate from the other conditions. As we discussed, it's one of the primary headache disorders. But the reason it stands out is because it's the most disabling headache condition, the most prevalent disabling, headache condition. So it's quite common and quite disabling. And it peaks during the productive years of a patient's life. So it's quite common to meet migraine patients suffering with the disability of this disorder. That's why it stands out.
Perfect, thank you. And our last question is, you mentioned that employers and HR managers should be trained to face situations where their employees suffer from headache disorders. So to the best of your knowledge, are there any programs that involve this kind of training? And if so, how successful are they?
There are not that many specific programs, I have to admit. The International Headache Society with GPAS, the Global Patient Advocacy, have tried to put together some advice in the blog to train employers in HR. They're still at the beginning, but overall, the International Headache Society has been doing some work with certain companies, big companies, that try to educate them, not only the HR managers, but also the employees. So there's a specialist giving a lecture at the workplace, advising on the headaches, similar to what we did today. So these programs, I found them personally the most effective ones, because you are in direct access, you have a direct access to the HR managers and to the employees suffering with the headache. But as I said, they're still in a very infant state.
Perfect. Thank you so much, Anna, for sharing your valuable knowledge about the impacts of migraine and headache disorders on the workplace, and also the socio-economic burden they may have. We thank you again for giving various recommendations for employers and colleagues on how to recognize symptoms and how to approach headaches and migraines in the workplace. So thank you, Anna.
Thank you. It has been a pleasure, and I think it's a very important aspect, and thank you for covering it.
Perfect. Thank you for hosting this webinar. And to our audience, thank you so much for your attention and interest in our webinars. All of our webinars are created for public access